Hello and welcome to OffBlueMedical. Today we will discuss more high-yield topics in quality improvement and patient safety. So to get started with the first topic is going to be PDSA, which is the Plan Do Study Act. It's also abbreviated as Plan Do Check Act on the USMLE. So these terms are used interchangeably. This is basically a cycle to make a change. So you start by planning something, and you should answer these questions: what, where, and when, and then you do the change, study the outcome, and act accordingly. So let's do an example. So let's say you have infections, okay? Infections that result from inadequate hand washing. So physicians don't wash their hands, so there's a lot of infections in your hospital. So what you're going to do is that you're going to plan something to change this. What are you going to do? Where are you going to do it? And when are you going to do it? So maybe we will tell doctors to wash their hands 2 times, 3 times before they enter a room every day. So this is the plan part. After you plan, you're going to do the change, you're going to implement it. After you implement, you study the outcome. So let's say at a specific month before you did the PDSA, you had 20 infections. Then after you did the plan and you did the change, you studied the outcome and you saw that there were 15 infections or 10 infections instead of 20. So it was reduced in half. Then you study the outcome and you're going to be like, okay, this is good. 10 infections instead of 20 is good, but I want it to be 0. So I'm going to act accordingly. Maybe you will do 4 times washing per day, or you're going to implement monitoring for physicians and notify each physician that doesn't wash their hand. So this is basically a cycle where you plan, do, study, and act. You plan something, then you are going to do it, then you're going to check and act until you solve it. So a question that may come up is like this one. So it says a general surgery ward notices a 20% increase in post-operative wound infections over the past quarter. The hospital's patient safety committee forms a team to address this. The team hypothesizes that inconsistent preoperative skin preparation is a contributing factor. They develop a standardized checklist for skin prep. According to the model for improvement, what's the most appropriate next step? So basically, they developed a checklist for skin preparation to prevent post-operative infections. They did the plan. Now what are we going to do? So basically, if I write it, we have the PDSA. Okay, they said they developed the checklist, which is the P part. What's the most appropriate next step would be the do part. We're going to do it. So implement the checklist for all surgical patients in the hospital. This is premature because we don't know if this actually works or not, so we're not going to do that. Write a new hospital-wide policy on skin preparation. This is also premature. We're not going to write a new policy based on that. Conduct a small-scale test of the checklist, which we wrote, for 1 week. And this sounds plausible. Okay, but we're not sure. Let's read the last choice, which is going to be discipline the nurses. We don't really discipline people. We want to improve quality of healthcare by improving the system, educating people. We don't blame people and discipline nurses. So this is not part of the PDSA cycle. So the correct answer here is going to be to conduct a small-scale test of the checklist with 1 surgeon for 1 week. And then based on that, we're going to study the outcome and act accordingly. So C is going to be the answer choice. Another high-yield topic for the USMLE is going to be the Donabedian model, which is basically a framework to evaluate the quality of care. It has 3 important parts. It has the structure part and the process and the outcome. Basically, the structure is the setting or capacity to deliver care. For me, I consider it as physical or organizational factors. An example on that would be number of ICU beds available, number of physicians, staff to patient ratio. They are basically physical things. And then the process is going to be what's being done. For example, on that would be correct antibiotics being given to patients, and the outcome is going to be the result. So an example on that would be mortality rates, readmission rates, infection rates. So one other important part of the Donabedian model is going to be the balancing measures, which is a little bit more hard than these. For these, basically, structure is going to be physical factors, process, the actual process, and then you have the outcome. The balancing measures are measures to ensure that improvement in one area don't cause problems in another. So an example on that would be that a hospital implements a program to decrease the length of stay for pneumonia patients, which is a process improvement. The balancing measure would be to monitor the 30-day readmission rate for pneumonia to ensure that patients aren't being sent home too early. So a couple of other examples on this Donabedian model would be the first one, hospital hires more trained nurses. So which category is this? This is going to be structure. Did patients receive venous thromboembolism prophylaxis on admission? This is process. 30-day post-operative mortality reduction after policy change. This is an outcome. Which is the easiest to measure? It's going to be the structure. And which is the closest to true quality of care? It's the process. So a run chart is a simple line graph plotting a measure over time. For example, the number of infections per month is going to show trends, patterns, or shifts. It's basically answering the question of, is a problem getting better or worse? This is an example on it. You can pretend then that this is maybe a chart, a run chart for a patient's fever, and you can see the fever is fluctuating. Maybe it's here normal around here, it's going down, and then it's going up. So a run chart is basically something that goes up and down. If we want to complicate that a little bit more and make it harder, we're going to discuss the control chart. So a control chart is basically a run chart, but it has statistical things. It has the upper limit and the lower control limit. Basically has an upper limit and lower limit. So in this image you see here, this is the upper limit, and down below this is going to be the lower limit. So a control chart is a run chart with an upper and lower control limit. They are statistically calculated from the data. So this is going to help distinguish between normal variation and something that is significant. So there are two important things right here. The common cause variation, which is the random noise or normal fluctuation within the control limit. You don't need to investigate every little bump here. And there is a special cause variation, which means that there is something that's not random that happened, which is either good or bad, that needs to be investigated. So this image shows both of these. So this image is a control chart. If this was it, without the upper limit and lower limit, this would be a run chart, but we added an upper limit and a lower limit, and with a run chart, it's going to be called a control chart for USMLE. So this is the common cause variation, and these are specific cause variations. For USMLE purposes, you don't need to really differentiate between these. You just need to know that a run chart with an upper limit and lower limit is called a control chart. You just need to recognize this on the USMLE. Event reporting is a formal system that's used in hospitals to report medical errors or near misses. Near misses mean mistakes that were caught before reaching the patient. So here the goal would be learning and prevention, not punishment. It includes errors, active errors, and near misses. Both are equally valuable to report. They are anonymous and non-punitive, which encourages honesty. We don't encourage punishment, we encourage learning and prevention. So this is based on a just culture. The point of that is going to be to fix the system, not blame the individual. It's used for internal safety learning to prevent future harm. So the 6 principles of high quality care is going to be abbreviated by the mnemonic STEEP, which stands for safe. Timely, the three E's, stand for efficient and effective and equitable, and patient-centered. Safe means that care should avoid causing harm to patients. An example on that would be preventing medication errors, hospital-acquired infections, and wrong site surgery. Timely means that care should be delivered without unnecessary delays. So an example would be to reduce emergency department wait times and faster stroke thrombolysis. Effective means care should be based on strong evidence and known to work. An example would be to give ACE inhibitors for heart failure or aspirin for myocardial infarctions. Efficient means to avoid waste, time, supplies, money, and human energy. So example would be to avoid unnecessary testing or prolonged hospital stays, which are unnecessary. Equitable means quality of care must be the same for all patients regardless of race, gender, income, location, religion, no disparities or discrimination based on any of these. Patient-centered means that you need to include the patient when you make decisions. So it means care should respect individual patient preferences, culture, values, and autonomy. It includes shared decision making and communication. Maybe there is a treatment for a specific medical condition and there's other alternatives. You want to give, let's say, treatment A to the patient, but the patient doesn't want it. They want treatment B. So you should respect that and give other alternatives and include the patient in decision making and communication.